Hello, I am really excited this morning to be joined by Dr. Ray Middleton, who is a writer and deliverer of a lot of mental health training, including trauma-informed approaches towards mental health, something that I think is spreading within the mental health world, but still needs to spread much, much further. He's worked with homeless people and people involved in who have substance misuse problems. He's also been involved in a lot of really innovative mental health projects like Open Dialogue and the Power Threat Meaning Framework. And as he says himself, he likes to explain complex things in plain English. He's also had a number of different psychiatric labels, which he now lives without and lives outside of the psychiatric system, as far as I'm aware. So Ray, I'll hand over to you maybe just to tell the audience perhaps a little bit more about yourself, maybe expand on some of the things I've just mentioned.
Thank you, Brian. That's great. So just to kind of build on that a little bit, I suppose we're all on a journey in life, I think. And my journey through life, which isn't uncommon, was to end up in the psychiatric services in my sort of late teens and early 20s. And I had a particularly difficult experience there. So I ended up like long-term unemployed, and I ended up attracting lots of diagnosis through what's called a medical model. The kind of dominant way of understanding distress is at the moment, it is through a kind of narrative of science and medicine, really. And that tends to have typical things crop up there, like a diagnosis, tends to involve doctors, nurses, and you get treatment. So I got lots of medication, for example, chemicals, and I was put into a psychiatric hospital as an inpatient about 7 times during a kind of 5-year period in my early 20s, 20s really. And so in a nutshell, I found that didn't really help me get better. The idea about health is, it's okay as a metaphor, and it can be useful as in life. But health and treatment, and the idea would be to get better. And I got worse, basically. And it does, some people find some bits of that approach helpful. But in a nutshell, I was surprised at how it monopolized. It was like, the game of Monopoly. It was a bit like seeing my distress in that kind of very narrow way of, trying to see, did I meet the diagnostic threshold? Well, I met the diagnostic threshold for about 7 different diagnoses. So as I kept getting different ones through different psychiatrists, I started to get curious and puzzle about how come I was getting worse in this way of understanding distress. The chemicals were having quite a bad effect on me, like putting a lot of weight on and other things. And also my self-esteem, not working, seeing myself almost as my diagnosis. So eventually I found ways to get better outside of mental health. And then I spent the next sort of 20 odd, getting on for 25 years now, maybe, years kind of passionate about trying to work in that area with people with maybe lots of different kinds of problems. And I was sort of had a passion for trying to work out things that are helpful outside of that model. And I did a PhD looking at alternative to the diagnostic model. I accessed my own psychiatric notes, and I was raising a family, so it took a while to do that, but I did pass eventually, which was nice. And then I've got involved in writing and delivering a lot of training, and become a granddad now. And I enjoy life. I've still got problems because I'm a human being, but really I've got a fuller life, and I'm very fortunate because it's rare to have someone as unwell as I was, or as distressed as I was. And part of the process of getting better was realizing that really I'd had a lot of trauma in my childhood. And the reaction to the trauma was that I had strong emotions like anger and resentment, guilt and shame, because I'd been sexually abused as a child, which is very common, unfortunately. It's not that that doesn't happen to everyone, but it's much more common than is thought. And not just that, people experience all kinds of traumas, but my getting better was a process of kind of understanding in a different frame of reference, I suppose, which is I had a lot of emotion, which I and thoughts, distressing thoughts, which I found difficult and overwhelming. And so I used alcohol and drugs as a teenager and in my 20s to kind of try to manage those strong feelings of shame and guilt and anger and fear. And not just feelings, but there's thoughts that go along with that as well. Low mood. But when that made more sense to me, that it wasn't just random, it was, and when I worked out ways to process that unresolved trauma and get better and see myself in a different light, and I gave up alcohol and drugs about over 20 odd years ago, and do other things to get better, I could get on with my life. I got married, raised children. I'm a granddad now. I've worked for over 20 years. As I said, I've got issues. I'm not, because I'm a human being, but now I've realized I'm like everybody else. It's a continuum. I'm a human being trying to work out this thing about life, and there's different narratives to get better in. So I don't want to spend too much on it, but what I'm trying to give you a flavor on there is, it's possible. There's hope. It's possible for people to be quite severely troubled and find narratives or ways of getting better. There's a lot more ways to get better than medical science. And in fact, for me, I found it quite entrapping, because I used to then struggle with life and think, I wonder whether I need to see my GP or my psychiatrist and have my meds up or down 5 mil of this or that. And I ended up on lots of antipsychotics and lots of antidepressants and lots of mood stabilizers. And they kept adding to them. So I was full of chemicals. And so what I'm saying is, when I only saw myself within the medical science model, because I struggled with my identity and not having a job and fitting in, I kind of strongly identified with my diagnosis, which I don't now, but at the time I thought, this is an explanation of why life's so difficult, because I've got this thing. But instead of working out other ways to get better, quite quickly my thinking would go into that, what you could call a genre, a general set of expectations about, like, you're struggling, so maybe you need to go up or down your meds, instead of thinking, maybe a bit of voluntary work, I could get a paid job then. And although those thoughts were there as well, it's the weight of this kind of powerful set of ideas that I got trapped in. And there's lots of people who find some aspects of that helpful. So some people find it helpful and say, well, it helped me to get this diagnosis, because then, for example, the way the system's set up, I could then get an extension to my educational course, because I had a diagnosis of depression. So the world works, the system's set up where people need to some extent engage with that process. It's harder to get better outside of that, but it is possible. And there's lots of different ways, is my kind of summary from this point, this little kind of intro, I suppose, about my journey. And then I've just trained a lot of people who worked in mental health. And there's a big shift now to understanding trauma is a lot more significant and important than was first thought. For studies like the Adverse Childhood Experiences, or ACEs studies. And there's lots of alternatives now that weren't there 20 years ago to understanding distress in ways that don't have to necessarily be a kind of medical model diagnostic frame. There's lots of alternative ways to help people make sense of their narrative, really. That's what I'm kind of interested in. People have a personal story on narrative, and there's ways to change that narrative and get better. And I'm keen on trying to get some useful ideas out to more of a wider group of people, because often it's hard for professionals. You end up sometimes in a GP and you may not have had lots of training about this. So it's hard, because you can feel a bit like, I'm not sure what to do. So the easier thing to do is kind of go to something a bit more familiar, where there's lots of things that can help people get better. There's not just one thing helps, but there's a lot. Everyone's a unique individual to some extent on a unique journey, but to some extent we share some things with other people. My experience of using drugs and alcohol to self-medicate strong emotions from unresolved trauma is not unusual. So not everybody does that, but I had that in common with some other people, and some things we have in common with everyone, like the ability to feel emotions and to try and make sense of our lives. So there's a range of things there, about. But I'm, really passionate, hopeful that it's possible to get better. And I'd have liked to have known a bit of the stuff I know now when I was 19. So that's why I'm kind of keen on trying to share some of these ideas.
Yeah, thanks, Ray. Thanks so much for sharing all of that. And I guess as as a GP with the passion, a very, very similar set of passions as you have. Like, I guess my kind of logo, if you wish, is like pathways to well-being. I'm really passionate that there are lots of pathways to this thing we call well-being, or mental health, or happiness, to even use a more colloquial term. And I guess my experience is that I trained as a med student. I had very little, if no, trauma-informed training as a med student, and I've just done your trauma-informed course, and it's so digestible and it's so understandable. Immediately I find myself even looking out the window at people passing by in the street, looking at them with more compassionate eyes, with a more compassionate understanding, because you can see why people get themselves into really bad habits, because they're trying to find ways of coping with that really strong emotional hurt that they have grown up with because of either, as you mentioned, the adverse childhood events. So things like physical abuse, sexual abuse, emotional abuse, neglect, witnessing a parent with mental illness or alcohol or drug problems, witnessing a very confusing experience as a child of your parents separating. So you can then see why children develop into adults, and you don't really know how to cope with your emotions. And as a society, we're not really good at speaking in a kind of constructive way about our emotions. So therefore, it's easy to go into Tesco's and buy, a few cans or a naggin of vodka, whatever it is. And I guess from my experience, I went through university, and I would have thought that I had quite good mental health in university. But during my first year as an intern, working 60 to 100 hours a week, I found that basically it really crippled me. It really crippled my mental health. And without me knowing it until like 5 years later, I actually fit all the criteria for something called binge eating disorder. And I knew it as I was training for a GP. I came across this diagnosis, and it's not one of the big eating disorders. It's not like anorexia or bulimia. So you can go through med school without learning about it. But actually, it fit a diagnostic criteria. And then what really makes me curious about your story, or your actual real story, is that you recovered outside of what we call the medical model. And I chose not to go to a GP or a psychiatrist, even though I thought of going to a GP during the time. And I recovered outside of the medical model. And I think part of the reason why I steered away from going to a GP is because I'd done like 4 to 6 weeks with a GP training. And I'm not telling people not to go to their GP. That's not my message. But I guess what I am perhaps raising awareness of is that as GPs, we are really limited in what we can offer in 10 minutes. Like what you're describing in your training, the idea of like really building trusting relationships, and listening, validating people's experiences, and coming up with like really gradual but real ways of helping that person meet their goals, is really, really challenging to do in 10, 15 minutes. When we've been trained in this process of, well, what my job is here is to find a label, find a diagnosis, code it as that, and then use the guidelines, which typically point me towards like CBT or drugs, and maybe with some discussion of lifestyle. But what you're describing actually is that we could train so many more professionals, so that people off the street in distress could be met with an approach where people have time, where people are understood psychologically and emotionally where they're coming from. So I know I've spoken a little bit now, but I'd be interested to hear your feedback on what I've shared, but also maybe just a little bit about the nuts and bolts of your recovery. So how did you step away from that person you were as with X and Y diagnosis? How did that change for you? So that you are where you are today, where you're grounded in a much more mentally healthy place day in, day out.
Happy to sort of explore that a bit and share a bit about it. I think just to respond to what you were saying there to start with, what I'm really keen on is helping everyone to see that anyone can make a helpful difference to someone else's well-being, mental, emotional well-being. And And I'm not, I think it's really helpful to have a professions. And so I'm not against professions, but I think on a bigger scale in society, what has happened is that we've kind of subcontracted mental and emotional well-being to professionals too much. So it's become over medicalized and over professionalized. And the unintended, I think it's unintended consequence, because the way power kind of works, it's often unintended. It's not like someone's designing to do this. The unintended consequences is that the average person, even if you have a profession like being a GP, the average GP feels, oh, that's very complicated. This mental health problem. And so people become feeling disempowered themselves, or they don't feel they've got much agency. So if someone, as a friend, so even just on a level of friendship, or a colleague at work, or a family member, people often quite quickly feel, oh, I feel that this person has lots of problems. I don't feel I can do anything. When actually there's lots that you can do. And sometimes it's important just to remind people that as human beings, if you listen to someone, that's really important. If you validate, and just by summing up and hearing what they said and summing up what they said and saying it back, so that they hear that you've been a witness and you're validating that they are distressed and they don't know maybe why they're distressed. This is really helpful and useful. And it might sound obvious for me to say this, but I think sometimes we don't realize the good we're doing, the therapeutic good we're doing just by listening, validating. Then sometimes what we can do is help to build people's motivation, for example. And there's techniques we can use to do this, but some of them are very straightforward and simple. It's not rocket science. It's sometimes people feel overwhelmed by the problems, so you can break it into little manageable chunks. So you help someone, because it's hard for people to think when they're overwhelmed with emotion. So by listening, you can be a bit of like an emotional container for that person, because instead of feeling overwhelmed yourself, you can maybe say, I can see you're really finding you're really tired at the moment, maybe distressed, and you're feeding stuff back. You say, well, maybe if you broke that desire to maybe you want a better job, maybe, or a paid job. If you broke into manageable chunks of, maybe, I'm just using this as an illustrative example, I suppose, into smaller steps on that journey. Often people look at how they'd like, the good life they'd like, feel overwhelmed, and then retreat into like unhelpful habits, like maybe whatever those are. There's loads of unhelpful habits out there that people might develop. But instead, you could be the listening ear that's quite therapeutic, listening with compassion, allowing yourself to kind of emotionally connect with that person as you listen to them as well, because they pick up on that you care about them. You don't have to have all the problems as well. You don't have to have all the solutions. You can just listen. And I'm using this as an example, is that we can help people then say, well, that's good that you've got this hope for this good life like this. But I wonder what the first step would be. Would it be having a look at what voluntary work's available in the local area? Or it could be all sorts of things. They might have a job, but there's something else they would like. But by breaking it into manageable chunks, it's just technique for building motivation. So instead of thinking that's a mountain I can't climb, think, oh, that's base camp. That's the first little bit. I could kind of go on a little journey here. I've got support. And then there's also collaboration, which all that means is about trying to share power. So when someone comes to us with distress, I'm a bit like this. My impulse is to want to help. And so I can take a little bit too much, like over help people a bit. Instead, I want to empower them to say, well, there's things you can do. So collaboration around problem solving is about sharing power. And again, this might sound straightforward, but these things help people in terms of their emotional well-being. So instead of me saying, oh, I'll do X, Y, and Z for you, which is quite an anxious, impulsive response, a well-meaning one, but it can be unhelpful, because it can, if I help someone too much and do too much for them when they're feeling distress, it can disempower them. So they get the impression, oh, I'm not very skillful at life and Ray's helping me do stuff. But a more helpful thing to do is to say, well, why don't you do some stuff? You have a look on the internet about what's available, and I'll do some stuff, and we'll have a chat and meet you for a coffee on Tuesday. So what I'm doing there, or anyone could do this, is rather than anxiously trying to rescue or save that person, I'm saying, you've got a set of knowledge and skills. We've all got some skills and knowledge. They might vary. You can do some stuff about your problem. I'm building up their sense of agency. And when people feel overwhelmed, they often feel I'm powerless. I can't do anything. I know I did when I, was in that kind of cycle, caught in a kind of cycle of going around, stuck. And so all I'm doing there is giving a flavor of very practical things we can do. We can listen compassionately. We can reflect back what we're hearing. And that's helpful, because It takes the pressure off people a bit. It helps them see themselves in a slightly different light, because we're like a mirror, helping people to reflect. It's not that I'm a perfect mirror. I've got my own faults. There's things I can't see. But then they might see things a little bit better, because I'm being a bit of an emotional container for them. I can validate that is difficult. I don't need to have the solution. So part of being willing to be an emotional container for someone is thinking, I don't have to solve this person's problem. I can just be there, compassionate person, journeying with them for a little bit of time on the journey. We can help to motivate people to be hopeful, hold hope for people when they don't have hope. We can share a bit of power about collaborative problem solving. We don't need to have all the solutions. We can just say, oh, you could probably do a bit of this. Remind people that they have got a bit of power. They're not powerless over these difficulties. They're not all powerful either. We've got to kind of work out a bit of in a humble kind of way, like we've got some agency, but we can't go to the moon this afternoon, because I don't have that money, I don't have a rocket. So what can I do? What can't I do? But you can help people bear each other's burdens, as it were, on the journey. So that's a bit of a flavor, I suppose, I'm sharing about very practical things that sometimes we dismiss that we have in our ability. It is hard if you're in a job where you're a GP and you've only got 10 minutes. I totally understand that. But partly it's trying to think the only solution isn't just to kind of get into a very highly medicalized professional version of interpreting distress. Actually, it's normal to feel distress. It's normal to have unresolved trauma and to try and resolve those traumas. So that's my response to what you said. And I'll keep it brief, but I suppose my own journey, I suppose this wouldn't be everybody's cup of tea, but I had a faith experience. So spirituality was important to me. I became a Christian, and it was in a context of a very caring church. I mean, some people might have had difficult experiences of church, and I hadn't experienced a church like this before, but it was a caring church where they cared for me. They were lively, but they genuinely cared for me, and they accepted me as I was, not as someone who hadn't worked for 5 years or any of my psychiatric labels. They invited me around. I hadn't worked for 5 years, and I was very isolated socially, and they invited me around for tea to their house with a house group family. So I felt there was something about being accepted as I was, and they also believed I could get better, and I kind of picked that up. So it's being part of a community, a sort of small church community, inner city Bradford it was at the time. Now I live in, that was about 25 years ago, but now I live in a little coastal village in Northumberland, and I'm still active in my local church, and that process was helpful for me on a number of levels. I think partly finding a role in a local community. In this sense, it was a church community, a faith experience. And then some of the practices in that form of spirituality, asking Jesus into my life is, for example, I forgave people who'd harmed me. Now, I used to be very resentful about being harmed, and being, say, sexually abused. And I know it's a very emotive thing, and I completely appreciate that not everybody's journey to well-being will be through Christian practice, but I'm just being honest about my journey. That's how I got well. So I was part of a community of people who were imperfect. I'm imperfect, but genuinely cared and were actually meeting up, having, being social, caring about each other, loving each other, trying to, but also forgiving people relieved me of this anger and resentment. And so when I forgave people in that spiritual practice, I didn't feel the need to use alcohol and drugs and amphetamine anymore to try and manage that strong emotion, because that resentment wasn't there. And there's other things I won't, take up too much time by talking about them, but it kind of gave me a kind of narrative to orientate my life within, which was a faith experience, which is different. It's a good example, actually, of something. There are things available that are not medical science. There's more to the world than medical science. And there's lots of other things out there. I mean, on that journey as well, I ended up getting a job, voluntary work, and then I got a paid job in a bookshop. And I met my wife, my future wife, and got married. And then I became a father. And so I got on these roles, I suppose. I took on these roles and responsibilities, which helped me to look after. I'm not very good at self-care. So I suppose as I went on that journey, there was some very practical nuts and bolts, like giving up alcohol and drugs. But then there was other things about healing the underneath stuff, like the hurts. And there was the sense of community. So I wasn't trying to do this on my own. And having some roles in this kind of active church community as well, that, you know, could do, it meant I felt I belonged to something. But I also got some paid jobs in kind of the world of housing support, mental health, and ended up, you know, learning a bit about the impact of trauma then. And I had a helpful psychiatrist at the end who 20 odd years ago who kind of was open-minded about saying, look, you're probably going to get better outside of mental health services. So he was happy to kind of let me go and sign me up. He didn't have to anxiously, you know, to say. And so I was very fortunate, because then my wife's been very supportive, you know, like, so I wouldn't downplay any of these things. I was very fortunate in meeting my wife, who I love, and we love each other, and like with all marriages, we, you know, challenges, but we love each other. So that's been very therapeutic in a sense, more than anything else going to be in life, was loving each other, you know, in a relationship, not without its challenges, and having roles and responsibilities helped me think, well, I better look after myself because I've got children to raise. So that helped me when I was outside of mainstream society, not working. Because I had nothing to lose, I didn't care about myself. I didn't really have that incentive to care about myself. When I had some roles and responsibilities, that motivated me to think, well, try and look after your mental well-being, I suppose. And at work helped, and with lots of things. And I'll end on this point, I suppose, in response to a little bit more about how I got better outside of like the medical model. Work helps. I've got quite a strong work ethic, but like with lots of these things, it's a bit of a threat response. So I cope with my own feelings of maybe inadequacy and difficulties in life by working. And I wouldn't put that down, because it has helped me over the years, and I'm not going to, but it's possible to do any of these things that help you cope too much. So I can overwork and burn out. So I've got to be careful about these cope. You could call them a way to cope, or a threat response. So I do work, and that helps me to be well. I'm giving you a flavor of different things, like, you know, being married, having roles and responsibilities, being part of a faith community, and having a job that I enjoy doing, I'm passionate about. But it's also a weakness, you know, like too much of anything can become a problem. So in my own kind of journey of healing, I'd still say I've still, you know, I'm as work in progress. Mm-hmm. I'm aware now, more than I was even 10 years ago, that my tendency to overwork to some degree helps me stay well, and I function that way. I'm a little bit, you know, obsessive overworker, and I feel useful to people then, because if I write some training and stuff, or deliver training, I feel useful. But on the other hand, I can overdo it, and that can harm me and harm the people around me, because if I'm, you know, if I overwork, then I can get burnt out. I have got burnt out a few times. So I have to keep an eye on that. So hopefully that gives you a flavor of me answering your question, really, but saying that it's not that you're fixed or not fixed. It's kind of,
sure.
We're on a little journey.
Yeah. You're always in a process, aren't you? Life is always
process.
Yeah. What a couple of things struck me, Ray, about what you said. So one was about the faith experience, and I think that's really interesting, because again, in medical training, I remember we had this discussion with a psychiatrist in our GP training, and basically the conclusion that we came to as a group is, don't ask people about their spirituality or religion. And for me, like, I left that meeting feeling, this isn't quite right, because whether you're religious or spiritual or not, there's something about trusting life and trusting perhaps something that's beyond life. And it can be Christian, Buddhist, it can be simple nature that you have a faith in, or something that you can kind of feel like you can kind of, for want of better words, you can give some power over to, because we live in a world where we have some power, but then there's so much that's beyond our power. And so I think it's really interesting, and it's obviously, it would be a big challenge to bring into conventional training of any sort, whether it's the medical model or trauma-informed model. But there is something about, for maybe just to conclude, my feeling about it is not to negate that aspect, because things like faith and forgiveness is another word used, is huge. Like, it's a massive thing. Any kind of framework, whether it's Christian or otherwise, that are perhaps a trauma-informed approach is another approach that helps us forgive other people. Because when we hold a grudge, it saps us of energy, and it makes us feel righteous in, for example, going to the fridge or taking alcohol. Somehow the anger justifies that response. Somehow we feel entitled to treat ourselves or other people poorly when we feel we've been hard done by. And that's a very human thing. And what I like about what you're describing is this kind of very human journey of like taking steps that are obviously very nourishing, like meeting someone that you fall in love with and that nourishes you, finding work that's somewhat nourishing. And I think certainly like all doctors have a certain sensibility about this. But again, just as you described almost being a little bit trapped in the medical model, I think a lot of doctors feel a little bit trapped in the medical model because it's what we're literally paid and trained to do. We're paid and trained to diagnose people and follow guidelines. But actually, maybe what this conversation is really pointing to, whether the model changes eventually or not, is about like, well, let's become sensible. Let's use our common sense, about these things. Like I was thinking the other day about guidelines, and our guidelines promote drug therapy very quickly in a lot of things. So like if you're moderately to severely depressed, the guidelines show, because there's hundreds of thousands of studies done on antidepressants, that they have a beneficial effect. But if you were to do a study that like to examine whether like 4 or 5 hours of fresh air with other people were to help reduce depressive symptoms, you'd almost certainly get a really significant reduction. But fresh air and good company can't fund itself. Like it can't use billions of dollars. It's not going to come.
Capitalism doesn't lend itself to it. It's not a capitalist kind of product.
No, it's not. It's not going to come knocking on a university researcher's door, is it? So that's the kind of thing that, like in mental health circles, often we negate these things that are just so commonsensical that help us in terms of our mental health. And that's what I really appreciate about your story. And one of the other things that struck me when we did a training together recently is you mentioned something like the narrative that you as a patient had in the medical model, which is, I guess, for people who are unfamiliar, which is basically the model that where we diagnose people in different degrees of distress or different forms of distress with what we often label to be mental illness and varying degrees, severe mental illness, mild to moderate mental illness. And then therefore that person has to manage that illness in kind of in a way that's somewhat doctor service dependent. And that's typically to some degree or another drug dependent if you're on the more moderate to severe scale. And you described in that training that on retrospect that was a little bit disempowering. And I know you also mentioned, and I would also be the first to mention, that it's not disempowering for everyone. But I'm just curious to maybe explore that a little bit more with you, and how perhaps other models, whether it's trauma-informed or the power threat meaning framework model, made more sense to you, or even the Christian model, just how maybe other models or other narratives made more sense. So I'm wondering about that transition of how you saw yourself, the world, and other people changed gradually.
That's a great question, Brian, and I'll try to link the two things, which is responding to your question, but also I think it's really interesting that you said, because I do appreciate and I have compassion for people who've been trained in the medical profession. It can be very difficult because there's a certain genre of that training, and there's certain constraints it puts on you and certain pressure to kind of be an all-knowing, kind of have all the answers, when often realistically, often in life we don't. So I suppose the first thing I'd say is it's a bit more than when you're saying the sort of tension of professionals to say, well, let's not mention faith or spirituality because it's easier, almost like, or it could get complicated. Or I think that's very, I understand why it seems easier to just kind of anxiously kind of restrict ourselves to a kind of that medical model. But what I'd say is it's quite unfair, and ethically it's not, it can be quite discriminatory because it's a diversity issue is what I'm saying. It's because whatever model you choose, it's not that all models are equally useful. And I suppose the point I'd respond to saying is, I think it's more helpful to choose a framework or a model that allows people to say that it's okay to have a faith or to not have a faith. But to have a model that says, well, we're not really going to think about people's spirituality or faith is unhelpful, because that's a big part of lots of people's lives. So even if you don't share my spirituality, which is faith in Jesus, as it were, or someone else might be a Buddhist or a Muslim, you might not share, you might be an atheist yourself. But even so, if you're in the helping professions, you need a model that allows you to listen to someone and say, that's important to you, even if you don't share that yourself. And so what I'd say is there's models out there, like a trauma-informed approach or the power threat meaning framework. I can say a little bit more about that to answer your second question, which at least allows you to say that some people have a spirituality is important to them, and faith. And so you need to be freed up to be able to talk about these things. I know, rather than thinking we're only going to think about in a medical model, are these symptoms, do you meet the diagnostic threshold for X, Y, and Z, etc.? And that's quite limiting, I suppose, or a bit restricting. So that's one thing to think about, I suppose, that my preference is towards frameworks or models or ways of thinking that allow more than one, allow us to think about holistically, that's the word I'm kind of searching for, more holistically about how human beings are, which includes lots of things, including not just that we're symptoms of we do or don't have a diagnosis. The second thing I found helpful is to actually think, is it if someone's struggling, you do want this kind of holistic approach where you can access things. So the power threat meaning framework, for example, to use an example, allows you to think, well, what's happened if someone's distressed? One of the questions it would ask would be, what's happened to you, rather than what's wrong with you. So the medical model tends a bit, and you want it to work well if you've got this opportunity to help people or with systems we're in, but it would say, well, what's happened to you with the power threat meaning framework rather than what's wrong with you. And that immediately provokes a bit more compassion with people to say it's probably understandable. And I think for my experience, to respond to your question, was when I saw myself as, say, I had a diagnosis of psychotic depression or bipolar affective disorder or borderline personality disorder, which is a very one that provokes a lot of stigma and prejudice in society. And other diagnoses, I got obsessive compulsive disorder, and eventually when I got to 7, I thought, hang on a minute, this is a bit crazy. Like, I might meet the diagnostic threshold. I'm not saying I didn't have lots of problems, but it just getting more and more labels wasn't helping me, and more chemicals wasn't helping me, and it restricted my thinking. So, and the best way I found to think about this, I kind of like a Russian bloke called Mikhail Bakhtin, who wrote quite a bit about narratives and different ideas. But he talks about genres, and all a genre is a general set of expectations, like a science fiction movie. If you went to a science fiction movie, Brian, and there was no aliens, no time travel, no other planets, you'd be quite disappointed, I think, would you? And so that's a genre. All a genre is a general set of expectations. And what the medical science approach to distress is a genre, which some people might find helpful, or more typically find bits of it helpful, and they take little bits that are useful and integrate them into a wider narrative of their life, where maybe they want to be a good parent, a good mum, or a good dad, and the more holistic narratives that we live a life in. So you've got the medical genre, but you've got other genres like spirituality, I've touched on there, the Christian faith experience, but you've also got other genres like educational ones, and you've got ones about employment, about people wanting a better job, maybe a more satisfying job. You've got lots of these genres out there about what the good life is, different ideas about it. So if nothing else, one thing to take away and help free medics up is to actually say, the medical way of looking at distress, medical science, is one genre amongst many. But quite often in training, it's hard to grasp that idea. And that there are other, a bit like a brand, you say other genres are available. People might find that they understand the distress in an educational one, in an employment one, and seeing more of the context is helpful. in terms of understanding distress. And I think one of the difficulties or weaknesses of the medical model is for me, it saw all my problems inside of me. Now, I did have some problems, and I'm not playing them down, but part of them were to do with what's happened to me rather than what's wrong with me inside. And so part of understanding the real therapeutic healing thing is to make sense of what's happened to me. And if I understood it, and that's a trauma-informed principle as well as a power meaning is a more specific kind of model. Making sense is like a really key thing to healing and getting better. And when I tried to make sense of it, think, oh, I've got bipolar affective disorder, it didn't make sense. It didn't help me get better. Now, I'm not saying for some people that is part of their making sense. They think, oh, I got this diagnosis. But then if you listen to what people say, is they say, because I had that diagnosis, I thought I better give up alcohol because it makes my bipolar worse. So that's a way in which people integrate a little bit of a genre from medical kind of there and say that's useful, because then they did something else. They made some changes to the lifestyle. For me and lots of other people, it's quite entrapping and damaging, because you get stuck in this place, which I touched on earlier, which is every time life's difficult, I used to think, oh, that's because I've got this diagnosis, rather than, oh, that's because I've got a lot of resentment about the past. And the medical model doesn't show you how to forgive people. You need to find some of these other genres to work out how to let go of this resentment and anger. So it's not equipped to deal with these ethical problems about, if I've been wronged and harmed by other people unfairly, how do I deal with that? So as a genre, it's just not set up that way, the medical model, to help people like deal with resentment.
Yes.
So having, and I suppose this is, hopefully I've responded to your question here. I'm just saying there's some quite easy wins here about takeaways, which is to see things as a genre, like science fiction movies and the medical model, and not to be really, just to say, acknowledge that some people find some bits of that helpful, but it's usually integrated with other genres and other ideas about the good life. And they could be a range of spirituality type genres, employment genres, educational ones, and we want to be whole and holistic. And it's a bit of humility is needed, I think, from the medical science approach, to say some of the things people get very distressed about, like being hurt by other people, which can be accidental, but quite often it's deliberate hurt from other people because of abuse, for example. It's not the only kind of trauma. It's not within that genre to know how to help human beings handle and process that hurts. And there's other genres that are available, like trauma-informed approaches, which are very easy to access, actually, because they're just promoting trauma-informed approaches. For example, say, what can I do to help people increase people's safety, to help them feel safer, because that's going to make them feel less anxious and they're able to better process things. So it's not really complicated. It empowers anyone to be a friend or a family member, a colleague, or anyone can help people increase their safety, to empower people, give them a bit more sense of agency. You could do something about this, give you a bit of hope, remind people that you can do things. You're not powerless about what you do with your life. You can make some changes here, increase people's choices, collaborate with people more. So rather than do things to people, instead say, well, what can we do together? So, and also trust is really important, because trust has often been undermined. It was for me in human beings. And so anything I do as a reliable professional, if I'm a GP, for example, or whatever role I'm in, or a family friend or a member, if I'm increased trust by actually not over promising people what I can do, but being reliable and doing that, that's valuable, because I'm increasing that person's trust in human beings. Not all human beings are out to harm you. Some can help, and trust can increase. So increasing those 5 things I've just mentioned there are the 5 principles of trauma-informed care, and anyone can increase those things to some extent by just thinking about, oh, if I turn up to my friend for coffee at 2, I'm increasing their trust because I said I'd turn up, or at least letting them know if I've got stuck and I can't make it. So knowing that building trust in human beings, helping people feel safe, creates these therapeutic safe spaces then for people, maybe just over an informal coffee, to explore their narrative. I could say a little bit more about that in a minute if it's helpful, but to think, well, am I stuck in a kind of narrative of seeing myself as the problem? Because I'm not really the problem. Human beings aren't the problem. Human beings have problems which are separate from them, but they've also a wider, holistic, they've got, they're a whole person and they've got potential to get better. So, try to give a flavor. I hope I've answered your question there, Brian. I don't know, like about the medical model, other things that are available, and how that might creating a safe space and allowing other ways to see things and not having to have all the answers can help people to kind of explore their narrative and alternative ways to make sense and orientate their life within. And some of those alternative narratives might help them get better.
Yeah, I'm going to respond in a couple of ways, Ray. So one is, I guess, just to elaborate on what you've just said in terms of, like, particularly childhood adversity, like the different types of adversity, so abuse or neglect or confusing childhood experiences result in a child and then an adult, or adult trauma is similar as well, feeling unsafe. So you feel unsafe, the world becomes really uncertain, and there's a kind of underlying feeling of fear. And it's really interesting, isn't it? Because I think with the medical model, as professionals, our sense of safety comes from following guidelines. And what we've learned, and what we find safety when something has loads of studies done to back it up. So we're reasonably confident in prescribing medication and in pointing people towards CBT, but we're not that confident in what you're describing, kind of the more as like the kind of more nuts and bolts of human relationships. And we as humans, we trust them, but as professionals, sometimes we don't trust them enough. Like things like you're describing, like listening to people attentively, reflecting back on what you've heard, creating conversations where you're helping that person make informed choices, where they've got options, not just of what to do, but perhaps about how they see themselves as well. And I guess to maybe bring up something a little bit controversial, I remember you saying at the training that, like, the medical model can give people the impression that they're chemically imbalanced and they need drugs to fix that chemical imbalance. And if people hear that, that's a really, really powerful message, something I'm really passionate about, because we could talk about side effects and withdrawal effects of meds, etc. But actually that message gives that person the idea that really, as you're describing, inherently there's something wrong with me, I'm chemically imbalanced. Therefore, any further proof, or like a feeling of wrongness, such as more fear, more anxiety, means that I must be more deficient in that chemical, therefore I need more of it. And I thought you said it beautifully in the training, that actually what's as true, if not truer, that people aren't chemically imbalanced, that people have suffered due to power imbalances. So classically, a child-parent relationship, or a child-family relationship, or even a child-society relationship, you're powerless to the poverty you find yourself in, or the sexual abuse or the physical abuse that you're subjected to. And part of perhaps a model of care, whatever we call it, that's more useful, that's more constructive, more sustainable, is helping people, as you described, find more agency, find more power in their life, in their choices. And it's really where I see kind of the crux of the matter in terms of where we're going, in terms of changing or what we're offering to people. So perhaps you can just describe a little bit, again, maybe whether it's your own experience or your training, how you see that kind of dilemma of, like, the medical model perhaps still having kind of like, even though a lot of medics question it and no longer kind of use that explanation, still kind of this shadow of the chemical imbalance idea, and therefore people needing drugs as kind of the first line. But you had, like, as you described, like depression with psychotic symptoms, but still somehow you found that drugs weren't the answer for you, that you found that somehow things that gave you more power, more choice, and things that were, I guess, nourishing for you, helped you to come out of that.
I could definitely respond to that, and it's helping me to remember, actually. So the first thing that came to my mind listening to you there, Brian, was how attractive the medical model was to me as a distressed person, because it offered an explanation. So my immediate experience of being caught up in them, getting diagnoses and medication, and I found it very positive at first. I mean, years later, I felt I'm trapped in this narrative. But first, I was very attracted to it because I felt a failure at life, ethically, morally, as it were. Like I thought, I was long-term unemployed. I seemed to be very chaotic. I use alcohol and drugs. I don't seem to have a relationship here. The things I wanted as a good life, I wasn't successful as a human being in terms of like the way society says what's successful. But not just that, what I actually wanted was a relationship and job and a house. I didn't want these things. It wasn't just a kind of ideology thing. I wanted them, but I wasn't succeeding. So what I was struggling with was how, I had very low self-esteem. At the time, I didn't realize had years of trauma, I suppose, as a childhood that had led to all this strong guilt, shame, etc. I was kind of I was aware of it, but I didn't know that was why I was so troubled, I suppose, in that kind of narrative explanation about, well, that's understandable, Ray, given what's happened to you, that you're probably struggling. So the point I'm responding to is it wasn't just it's very powerful to be in these professional roles of a diagnosis, medic, etc. But I also was very attracted to it because it suddenly gave me a narrative explanation to my family to say, the reason I'm not very successful is because I've got bipolar affective disorder, or I'm not, I've got psychotic depression, or I'm in and out psychiatric. I've got lots of medication. It's quite validating to be given lots of medication. It's difficult. So it probably, in those interactions with psychiatrists and with GPs, it was probably anxiety reducing for the GP to give me anti-anxiety medication, except, for example, it wasn't just reducing my anxiety, it was like reducing their anxiety as a professional, because the pressure was on them to have a solution, and to give diagnosis and medication was, as you say, it's backed up by the way their training is. It's more difficult, I suppose. And so that was the first thing I just wanted to acknowledge, is it's very attractive, and people, often I'd be saying I wanted medication or more medication because I didn't know there were other ways to get better, basically. So we ended up in being a bit caught. So it shapes your thinking, I suppose, is one thing I would say. And so it restricted my thinking, rather than thinking, there are lots of things out there. I could explore more about ways to get better, ways of understanding it. So my thinking often went to, there's something wrong with me, and the solutions are outside. It's a complicated thing wrong with me, so I need professionals to give me, long, complicated names. Understanding things in a remote context is a phrase from this guy Bakhtin, and often medical science and professions, it becomes remote context because they use increasingly complicated words. So I thought, wow, I've got borderline personality disorder. That sounds really complicated. Not very well explained either. So there's a little bit of humility needed, I think, to be able, but it's a difficult position to take as a professional, I think, to say, actually, you meet the diagnostic threshold for this, but there's alternative ways to understand it. You could have this medication, but actually it's probably not going to help you get a relationship and a job and a house. It will have a generalizing effect, which is a lot of this medication. And it might also put 3 stone, and you might get diabetes, etc. It's rarely explained in a kind of humble way to say there's limits to what we can do here, and alternative things might be helpful. So I've got a basset house, so you might be able to hear she's the just next to me, so you might be able to hear her sometimes. She's a bit elderly now, so I'm trying to give her a bit of TLC. So very therapeutic, actually, having pets. So all I've tried to do there, I suppose, hopefully I've tried to keep on track, is to acknowledge that as a genre, it's not just a powerful thing that's done to you, but these power imbalances are very difficult, very important, because there's a power imbalance between a professional and someone like me who's turning up with very little power at the time, very vulnerable, being offered an identity, an explanation. It could be because of this. And then it can be a bit entrapping. Whereas if we allow conversations about power, we want to empower people more and say there's things you can do. And it made me think, the professionals have the power to make me better. But actually, in the end, there were things outside of that profession that helped me get better, and things I could do and with other people. And so that's all to do with power, I suppose, power imbalances. And it's difficult to have conversations which say around power, I think. And it's challenging to think out of alternative ways to the medical model, because that's the dominant model. So it's often difficult to say, well, you could, what's other things are available. And what I'd say is personal narrative is a very helpful thing. We've all got a personal story, and that's something that we can help with. And we've touched on a few alternatives like the power threat meaning or the trauma-informed care. There's alternative ways of, you know, all the other things we mentioned, of making sense of distress. And so we want a more even playing field instead of all the conversations being dominated. So it's by, say, medical science. So I'm not against medical science, but I'm just saying, like the game of Monopoly was invented to try and show that monopolies aren't helpful. It actually can be quite relieving to professionals to think, actually, I don't need to have all the answers here. We could say, this is one way to understand it. There's other ways, and there's lots. And we want to kind of have a bit more choice out there about ways to understand distress. And the power imbalance is more significant than chemical. There's never really any evidence around chemical imbalance. And what there is lots of evidence around power imbalances and the impact of abuse, abuses of power, trauma, etc., in all its different ways, not just for children, but as adults as well, impacts people's emotional and mental well-being. And the power threat meaning framework just has 6 questions around your personal narrative, really, about what are your strengths is really important. You know, what's your personal story or narrative? What are your strengths? And that helps to see you know, we can help people explore that. But also what's happened to you in terms of how power has operated in your life. But also it can ask other questions about what's your threat response, for example. So, and that's a way to start to understand things. So I use the example of overwork. So it's a good thing, but sometimes my response to threat can be to work hard, but I feel not safe. And that can be useful as a threat response because it helps us to feel safe. Because the idea is that all human beings want to feel safe, but it can be unhelpful in extremes. So I need to kind of pull back a bit from that. But there's lots of other threat responses. So using substances is a typical threat response, or there's lots of ways of avoiding, you know, staying in your flat for 2 years and not going out can be a threat response because people want to feel safe. Mm-hmm. And that genre or framework of the kind of power threat meaning framework, for example, is very enlightening because then you think, oh, well, people are doing things because they want to feel safe, and you share that idea with people, explore it. You don't need to know everything. You're just kind of saying, I wonder if you're doing that to feel safe. And then what ways can you develop and move forward as a human being holistically, while still feeling relatively safe, to get better, to maybe solve problems, or if you want to feel less lonely, how can we work forward in a way? So all I'm saying there is those alternative models tend to, trauma-informed ones, and I'm giving one example there, tend to think, well, what's happened to you? And understand things like maybe being triggered is a typical kind of concept from there. Being triggered by something that's unresolved in my past might explain why myself or someone I'm trying to be helpful to or listen to might be reacting in a certain way. There might be threat responses like maybe using alcohol and drugs or avoiding people, or there's a whole host of them working too hard. And because this is very common for human beings, professionals roles are embodied by human beings, and they've got unresolved trauma. So there's loads of unresolved trauma amongst medics, for example, GPs. And that's why it's difficult to think about these things, because it triggers a little bit for professionals who may well have had a successful career, as it were, in terms of passing exams and getting, but they're human beings, and they feel anxiety and they get triggered, and they've got their own stuff. And so that's why it's kind of saying it's all of us is a much more helpful way than a them and us kind of some models of them and us, which is I'm the professional supposed to be like emotionally numb, cut off, and I'm just doing this. Actually, we've all got these kind of, we want to get better, we've all got some hurts, we're all like turtles, I think, you know, like turtles have a hard shell, but inside we're all a bit soft and we've got feelings. But so does that kind of respond a bit to this thing about power?
Yeah, that's great, Ray. It really resonated with me, and as I was listening to you, I was reflecting on how at times work makes me feel safe as well, and I can also overdo it. And it's a really, I love how it's universally applicable, no matter where you're at. You know, whether you're someone who's not that traumatized and feels reasonably well in yourself, you can still relate to what you're describing, perhaps on a smaller scale, to the person who has had a lot of trauma and is triggered much easier. but it somehow puts everyone on an even playing field. So even if you need to use a little bit of the medical model, you've got a new model to work with. And yeah, you've explained it really, really nicely there. I'm just wary of time, so I'm probably going to have to finish up shortly with the recording presentation.
Yeah.
But that was really, really rich, Ray. Really, really rich. I mean, like, we discussed quite a lot, really, like your personal journey. Like, we touched on the trauma-informed approach, the power threat approach, the impact of adverse childhood adversity around mental health issues, a little bit of the potential of discussing faith or religion, spirituality a little bit more. Is there any kind of final words or last message? I know people don't like that question, so if you don't, that's absolutely fine. If you've said so much.
I know. I think I'm happy to have a go. Bakhtin has a famous saying. I know. I like his writing. See, so he says nothing's ever finished. You know, so it's unfinalizable. It's any kind of dialogue. There's always what we've talked about. May kind of people might reflect on it a bit, and later on, people suddenly think, "Oh, haha!" And their response in their self and their emotions and their thoughts might be later, because everything has a response. So it's not a final word. It's just a kind of a pause, isn't it? And I suppose what I'd say is, what's helpful is to think that we're all human beings, and we all, to some degree, have trauma. Some much more than others. So it's not like evenly distributed, unfortunately. Some people have masses, and also people have different, they've been given different gifts of capacities to kind of deal with that trauma. So sometimes people have post-traumatic growth, for example, and get better from their traumas. You know, like I would describe myself as someone who's kind of learned from, and I'm a better human being from processing the difficulties I had. So what I'd say is, we've all had trauma, but some much more than others. And so models that help us to think it's about all of us is more helpful. So to see ourselves as a helper and someone we're helping, and mutuality is very helpful. That I'm a work in progress, the other person's a work in progress. I might have something helpful. I don't need to have all the answers. But these kind of frames and models or ways of thinking, we can all get a little bit better on that journey about helping people, even if it's just learning a few concepts like triggering and what that is, or about things that are helpful, like do people want to feel safe, and valuable things we can do, like building trust, listening. That empowers us to see there's things we can do to help people, because trauma is very common. So we don't want to have it a small group of people being the people who help people get better. We want to, everybody's business is about healing each other from our traumas. And the focus isn't really the trauma. The focus is about the good life we want to live and enjoy life. And in that journey, we need to be brave and be able to talk about the impact of trauma, because it's very common. And so I suppose that'd be my kind of takeaway as we end the chat, is I think the goal is, you know, as human beings, helping each other. And part of that is the growing in our capacity to talk about the different ways trauma can impact us, and ways to heal and get better and whole from that, of which there are many. But and it's on the journey to whatever, you know, that good life that we want to help each other on that journey is the focus. But to do that well, we need to not be stuck in all this unresolved trauma. So we need it to become a common thing to be able to talk about trauma, and it not be a shameful, stigmatizing thing to talk about trauma. That's why I share about some of mine sometimes. It's just to normalize it. Trauma is normal, so what things help, and we're all on a learning journey about it. That was a kind of takeaway.
No, thanks so much, Ray. That's fantastic, and I love the idea of mutuality. Like, we're all carrying different degrees of trauma, and I really love the idea of post-traumatic growth. It really resonates with my experience, and it's a really hopeful note to end on, I think. And so I'm just gonna stop recording now. Thanks so much, Ray. If people are interested in Ray's work, I'll put his website at the bottom of this video. His training is absolutely amazing. It's the best trauma-informed training I've ever listened to or taken part in. So please do check out his work. I'm just going to stop recording now.